Today's podcast is brought to you by the Bioceuticals Integrative Oncology Workshop with Dr. Lise Alschuler. This full-day program will run between the dates of the 20th and 28th of July across Melbourne, Sydney, Gold Coast, Adelaide and Perth. The intensive class will explore key concepts and therapeutic integrative strategies for breast, prostate, colon and lung cancers, as well as how to support toxicities associated with conventional treatment. By the end of the day, you'll be able to confidently implement this important aspect of patient care into your clinical practice. For more information and to register for this critical event, please visit the Bioceuticals website at bioceuticals.com.au. This is FX Radio and I'm Andrew Whitfield Cook. And with me on the line all the way from Chicago in the USA is Dr. Lise Alschuler. Now, Lise is the past president of the American Association of Naturopathic Physicians, and she's a founding board member of the Oncology Association of Naturopathic Physicians. She's received her naturopathic degree from Bastyr University in 1994, is board certified in naturopathic oncology. And she's the co-author of one of my favourite books, The Definitive Guide to Cancer, an integrative approach to prevention, treatment and healing. And she, along with her author, Carolyn Gazella, have created the 5tothrive.plan.com, and also she hosts a daily radio show called 5 to Thrive Live, which provides cancer patients with tools for living healthier lives. And you truly do, Lise. Welcome to FX Medicine.
Thank you. Glad to be here with you.
Lise, you'll be lucky to get away with talking for under 40 minutes today, but because I could talk to you for hours about your expertise. But first, I wanted to go back in time to your beginnings, because there's a few differences between Australia and the USA with regards to naturopathic training. So can you take us through, firstly, your naturopathic education?
Sure. So I went through pre-med at university level, and then naturopathic training in the United States is a 4-year postgraduate training program. There are currently 6 naturopathic medical schools in the United States that have federal recognition and accreditation, and that's important because that accreditation, of course, allows students to qualify for federal loans, and it also establishes the level of the training as a postdoctoral degree program. So we all graduate with a doctorate in naturopathic medicine. And then currently, I believe there's about 18 states that license naturopathic doctors. And if we practice in one of those states, we, of course, have to pass a 3-day board exam or 3-day licensing exam. Mm-hmm. And that qualifies us, if we pass, to apply for licensure, which we pay for. And then we are licensed in that state. When we're licensed, we really function as a doctor would. So we have to maintain the requirements of our license, which means we have to have a certain number of hours of continuing medical education every year. We have to pay for and retain medical malpractice insurance and, some other qualifications for just being a practicing physician. There are some states, of course, that don't yet license naturopathic doctors, and there are naturopathic doctors practicing in those states. So those doctors typically retain a license somewhere else, and then they practice in that state with a very limited scope. So typically a naturopathic doctor in the United States is able to diagnose and treat. We, like naturopaths in Australia, prefer to use natural substances. So we start with lifestyle and diet and herbs and nutrients, but then in the States we're also trained to use pharmaceuticals in some cases, and certain states we actually have a very wide scope and can prescribe quite a number of pharmaceutical medications and do some minor office procedures. But when we're in a state that doesn't yet license, then we can't do any of that, and we really are restricted to doing more lifestyle-based therapies.
And are there...
there's a bit of a range. We're still emerging.
And are there restrictions with the types of medicines that you're allowed to prescribe?
That depends on the state. Some states, as I said, have a very wide prescriptive authority, and that's because in those states, naturopathic doctors are helping to fill the healthcare needs in rural or disadvantaged areas, and they really need to have the ability to prescribe, pretty much anything a GP would. Other states, there's a more limited formulary that naturopathic doctors can prescribe, so it's very state-specific right now.
Right. So tell us about your training. What were the things that piqued your interest throughout your education, throughout your course?
Oh, gosh, so many. But, I think really fundamental, I was very focused on botanical medicine for a long time. After I graduated, I chaired the botanical medicine department at Bastyr University for a number of years, and really was and am quite taken with the power of plant medicine. So I think that to me was sort of always the core of what got me excited about naturopathic medicine in particular. And then I think just the philosophy of being able to take the time with people to really get to know them, to treat them as a whole person, to go on this investigative quest to try to understand the underlying cause of their maladies and to treat it at that causal level, to do our best to educate the patients so that they can be a proactive participant in their care. I mean, all of that just really got me excited and is so different than the way conventional medicine is practiced, at least in the States, for lots of reasons, most of which are not the individual doctor's fault, but more the system's fault. And, so I think it was just such a great thing to be able to step outside of that system and still be involved in healthcare. So I've been out in practice for about 21 years. The second half of my career has been focused exclusively on cancer care, and that's been very exciting too, and quite an evolution in our profession in the United States, because naturopathic oncology is actually the first clinical board specialty within the profession. So for those of us who qualify, we can sit for another board examination, and if we pass that, then we are eligible to receive fellowship status, essentially as a naturopathic oncologist, which is both exciting and really has helped to evolve the standard of practice, if you will, for naturopathic oncology.
So tell me about this, because you share your personal experience, and to me this sets you apart from many other practitioners because you know what the patient goes through. Did you have cancer before or after you were interested in supporting cancer patients?
That's a really good question. So actually I... about 11 years ago, I was given the opportunity to work at a hospital that specializes in cancer care. It's a hospital system in the United States, and I had both an administrative job and a clinician's job. So it was just a great opportunity for me to learn hospital medicine, work side by side with oncologists, and do naturopathic care in that setting. And during the time I was working there, I was there for about 5 years, but during the time I was working there, my father was diagnosed with pancreatic cancer, and fortunately, he outlived his prognosis quite significantly and really enjoyed a very healthy and well life. But that was, really taught me a lot about cancer from a very different perspective. And then I left that hospital setting and went to practice in an outpatient basis, which is what I do currently, and was doing that among some other things. And then I myself was diagnosed with breast cancer, which was kind of a shocker, but set me on another course of deep learning. And from that, have really grown in my understanding of what the impact this disease has on people's lives. So I was actually specializing in cancer before I was diagnosed myself, but that diagnosis has certainly changed the way that I both approach the disease, work with people diagnosed with the disease, evaluate what's important in, my therapeutics. And so it's been a gift, a hard one, but a gift nonetheless. Yeah.
Because I've got to say, it was the thing that made you shine when I first met you at the IFM 2010. I'll always remember you standing up there saying, to all of you people that say to your patients, don't eat ice cream, listen to this. If ice cream's all you can eat, then get it into you.
Right. Yeah. Yeah. I think sometimes, as natural practitioners, we have a lot of ideals about health, and, these ideals we hold tightly, and they're very valuable, and they're important, and they're they're right, but we also have to be flexible with our ideals. And there are certainly times when that flexibility is the necessity.
Yes, that's
like when people are in the midst of chemotherapy sometimes.
Yeah. And this is going to be something very exciting because you'll be coming back to Australia in July and you'll be delivering a one-day intensive cancer support class to various centres around Australia. So I got to say, I can't wait to welcome you back. But I need to ask you, what sort of things will you be covering during that intensive class?
Yeah, I'm very excited for this, and I'm only sorry we only have a day because there's so much to cover, but it's going to be as we say in the States, it's going to be a roller coaster ride. We're going to take people through fast and furious, and the intent is to start the day off with sort of an updated understanding of carcinogenesis, because the research is just pouring out, and we're discovering new things all the time. Like the most recent thing I've been looking at are these little messenger RNA molecules that cells spit out in these little exosome envelopes, and they end up carrying messages to the cells around them, and those cells repackage those same materials and send them back to the cells and cause that cell to behave in certain ways. I mean, that's just fascinating stuff, and that lies now at the heart of at least as part of our understanding of cancer causation and tumor development. So we're just learning all sorts of new things. So I'm going to cover some of that. And that's important because there are implications for how we as natural practitioners approach cancer, the more we understand, what it is and how it develops. And then we're going to go in and we're going to tackle the 4 most common cancers. So we're going to go through breast cancer, prostate cancer, colon cancer, and lung cancer. And with each of those, I'm going to try to give a very thorough update so that people sort of feel informed about the current conventional attributes of treatment. But then mostly we're going to spend some time on the natural approach and highlight some key therapies. And throughout the day, we're going to have some Q&A sessions, and then we're going to end with a panel discussion. So there should be a lot of interactivity, and at the same time, hopefully people will leave with a very usable manual that they can put into practice the next day.
So, Lise, a little bit of a rhetorical question, but if natural therapies are so broad in their approach, why do we need to differentiate between the treatment of various cancers?
Yeah, that's a great question. And I think the answer is, I guess I would say on 2 levels. Number one, oncology is a very highly evidence-based disease, so that there's a lot at stake. In many cases, the patient's life is at stake, and oncologists, generally speaking, are a bit reticent to take people too far off the proven path. Yeah. So when we come in with therapies that we want to integrate into that course of treatment, it's important to do that with a very good clinical basis for these therapies. So sometimes the specificity of treatments for each cancer type is really just where the clinical evidence has proven that therapy has some value. Yeah. That doesn't necessarily mean it's not applicable to other cancers, but we may just know it's applicable to certain cancers. Yeah. So that's part of the answer. I think the other part is that even though there are certain generalities across all tumor types, there are also specific nuances that are relevant to one cancer over another. For example, in breast cancer, there's a lot of crosstalk between the healthy stromal cells around a group of tumor cells and the cancer cells that is in that, and that crosstalk is heavily influenced by insulin and insulin growth factor and the level of adipose tissue that somebody carries. That's not as relevant, at least as far as we know, in, say, lung cancer. And then again, in colon cancer, there's a whole different array or influences on inflammation, which result in, activation of other pathways that if we understand that, can apply therapies to in a very specific format. So there is also a little bit of cancer-specific, I would say, tweaking or nuances that we can do. Yeah.
Lise, what's the newest evidence with regards to dietary interventions, both as lifestyle advice for people with cancer, but also as a therapy?
Yeah, there are some new understandings. I guess with lifestyle in general, there's an increasing understanding of the role of exercise and the specificity of the type of exercise that is most beneficial. And by that, I mean the degree of intensity of exercise. There's been some really good research on the level of vigorous exercise that seems to be most impactful, especially for certain cancers like prostate cancer.
This is short-term intensive,
getting
right?
more clarity on how much exercise one needs to do, and even to some extent when somebody needs to do the exercise. So that's certainly an emerging body of evidence. From a dietary standpoint, there's, I would say, emerging theories. I think there's still a lot that's in research stage, and it's not been, super well validated from a clinical data perspective, but nonetheless, at least in the States, a lot of practitioners are already applying some of these dietary strategies. So, top of the list would be things like the ketogenic diet. There's also a lot of research now on the role of insulin growth factor 1 in tumorigenesis and the influence that various low carbohydrate diets and or diets that include some degree of fasting or caloric restriction. And on that note, there's several clinical trials ongoing right now in the States that are looking at calorically restricted diets at the same time that somebody's receiving chemotherapy as a strategy to minimize side effects. So I think that those are probably the more recent, I guess, dietary strategies that are under investigation. And of course, there's always, more studies that come out on individual foods and nutrients that are exciting.
Lise, there's controversy over the term antioxidant in how we used to think they acted, and the new evidence suggests they don't actually donate an electron to never be used again, but rather we use these compounds as redox substrates. What's the newest evidence, and should we perhaps be thinking of different ways to term these foods that we used to term antioxidants?
Yeah, I think that we've gotten ourselves in a whole heap of trouble by categorizing a hugely diverse and heterogeneous group of compounds as antioxidants, and where, in fact, many of those compounds, as you suggest, are redox compounds, so that they help to maintain the redox balance of a cell. But even a classic antioxidant, something like glutathione, is actually has very diverse functions in the cell, many of which support the health of a cell, and could even have direct, anti-cancer effects. Primarily, for example, in the glutathione's role as a mitochondrial resuscitant, as a protectant, and the mitochondria really determine the fate of a cell in many regards. And then there's, I think, as we understand more and more about how signal transduction happens from the surface of a cell all the way through to the nucleus, we are beginning to understand that when a cell is exposed to oxidative stress, there are multiple reactions that happen simultaneously, some of which activate so-called antioxidant responses and some of which activate inflammatory oxidative responses. And it's really this very delicate balance between those responses that seems to be of more criticality in understanding what cells are under duress and which ones might actually be rather robust in the face of oxidative stress. And then, of course, we have to overlay the continuum of time on this because particularly when somebody is thinking about this in the perspective of cancer, the role of oxidation during active chemotherapy or radiation takes on a very different flavor than it does, of course, if we're talking about prevention or even recovery from those treatments. And, the actual lifetime of the so-called antioxidative molecules themselves come into play. So, this is a very complicated, very nuanced, complex discussion. And I think that that's good because what that does is really disallow us to make these gross generalizations, which many people still make, along the lines of, don't take any antioxidants during treatment. That's just not serving anyone. No. It doesn't mean anything because of all this complexity underneath. So I think that in many ways, naturopaths and other integrative practitioners are the perfect group to really dive into this, because we like mechanisms, we like understanding why things happen, and this is a great opportunity to do just that.
Yeah, I think once we do away with that closeted mindset of what an antioxidant is, we can then start to really engage in, well, what do these compounds do?
Right. Yeah, exactly. And, even the role of, one of my very favorite compounds or classes of compounds are polyphenolics or bioflavonoids. And if you look at bioflavonoids, they're often referred to as having antioxidative effects, but in reality, they actually introduce oxidative stress intracellularly. And in doing that, they tend to, though, create a response on the part of the cell that favors the activation of NRF2, which is an antioxidative kind of determinant.
Yep.
So they end up having a bit of a overall antioxidative effect, but in reality, they do that through an oxidative stress mechanism. So that's just one example of how things can get very muddled if we just sort of pick one piece out of its very wide spectrum of actions.
Yeah. So you're referring there to the mitochondrial senescence, if you like, or hijacking by the cancer cells. And if you sort of provoke the mitochondria with an oxidative stress, that it sort of kickstarts it back into its normal cycle. Is that what you're talking about?
No, not so much. Well, there is that too, but with flavonoids, I was more specifically referring to these NRF2 and NF-kappa B are kind of held docked in the cytoplasm.
Yeah.
And under oxidative stress, they undock and they dissociate. They travel through the nuclear membrane, and then they bind to certain parts of the DNA and in turn code certain genes. And NRF2 tends to code antioxidative genes, and NF-kappa B more pro-inflammatory genes. To your point, NRF2 has been implicated in restoring the mitochondrial sort of health, I guess, for lack of a better word, or the antioxidative potential, keeping the mitochondria more able to respond to oxidative stress that the cell encounters and restore itself from that oxidative stress. So, yeah, there is that connectivity to the mitochondria, which actually is a good point that you made, because mitochondria are, again, emerging as such a critical player in understanding the fate of a cell. So, understanding how to keep our mitochondria healthy is becoming more and more critical.
Yeah. There's a poster child of natural cancer support, and that's curcumin. What's the latest news with curcumin? I read recently that MD Anderson Cancer Centre was undertaking a trial.
Yeah, and actually that, just to bridge our last question with this one, then I'll get out of the world of molecular biology. But one of the reasons why curcumin is so effective is that it's a very effective blocker of that NF-kappa B inflammatory response, and at the same time it stimulates that NRF2 kind of anti-inflammatory response. So because of that action, that dual action, it has a lot of implication and a lot of potential benefit. And it's been studied now in dozens of clinical trials with really interesting results, ranging from being an antidepressant in one trial to having very effective anti-inflammatory effects in various retinal diseases and ocular diseases, all the way through to having some suggestive impacts as an anti-cancer agent. And there are more trials that continue to be done. There's a lot of different formulations of curcumin. There was the most recent trial I'm aware of with curcumin was one that was just released from, I can't remember the university, but they compared actually various formulations of curcumin one to another. And although there's still some questions about the dosages being used that weren't exactly equivalent, it appeared in this trial that the theracumin had, significantly greater bioavailability than any of the other curcumin ingredients. So that's a good trial. There still needs to be more trials done on that kind of comparison, but at least we're really starting to get specific about our curcumin.
Are there any real contraindications that you've seen with curcumin?
There's a couple of There's a couple of chemotherapeutics that it's not to be used with. Cytoxin is one, or cyclophosphamide is the other name. The action of curcumin actually is directly interferes with one of the main actions of cyclophosphamide in inducing cell death. So that combination should be avoided. There is some theoretical, and I say theoretical because it hasn't really we haven't seen this clinically, but curcumin could interfere with anticoagulant medications, and so I'm usually pretty cautious there. But as far as disease states, I don't really know of any contraindicated diseases.
I've been recently annoyed by one of the online medical reference sites stating that curcumin should be avoided in estrogenic cancers because it may have an estrogenic effect. And I can find zero data to support this. Even their reference that they gave was really an in vitro type of thing. There was nothing in vivo. Have you ever seen, heard, or had referred to curcumin being contraindicated in breast cancer or any other estrogenic type of cancer?
No, I have not. And like you, I would be very surprised if it has any clinically relevant estrogenic activity. I mean, look, anything in a petri dish can probably at a high enough concentration, and especially if it's a complex substance like a botanical, bind to estrogen receptors. But that means nothing as far as whether it's actually estrogenic or even phytoestrogenic in the body. And I just don't see that with curcumin.
Lise, mushrooms, one of my favourite interventions. What's been your experience, and tell me what the new evidence shows?
Yeah, mushrooms are one of my favorites. They are definitely a go-to, and they should be, I think, on everybody's shortlist. They're so impactful to obviously immune function, but most importantly, the holy grail of all, survival. In fact, there was a small meta-analysis which was done actually of 13 trials, and these were trials of using Coriolis or turkey tail mushroom, or PSK, which is the extracted compound from Coriolis. And what they found out was that overall survival at 5 years was improved with a statistic of a 9% absolute reduction in 5-year mortality, which means that there was one additional patient alive for every 11 patients treated. So the number needed to treat was 11, which is actually a very low number.
Yeah, it's huge.
And in oncology especially, a drug that had those statistics would be a blockbuster drug for sure. So, I think that's just an example of some of the data that is available to support our natural therapies. And mushrooms have so many other benefits. They're natural aromatase inhibitors, which has certainly application for people with estrogen receptor positive tumors. And as we know, of course, they're just really good immune stimulants, so they can help reduce risk of infection. So yeah, I'm all about mushrooms.
Do you tend to stick to the patented forms of each type of mushroom? Like you've got your activated hexose correlated compound, you've got PSK, you've got Mitake D fraction. There's all of these various patented forms of mushrooms. Do you tend to stick to those, or do you use the whole mushrooms? Or
I guess I have to say I tend to go towards what you call we call them branded in this country, but you call them patented mushroom extracts more often, just because I think that usually if somebody is in a situation where I really I'm trying to augment their overall survival, I tend to go towards those ingredients. However, that being said, they are expensive. So I often find patients get pocketbook fatigue after a while. And in that case, I'm very comfortable moving into whole mushroom extracts. And there's some really wonderful whole mushroom extracts available that I think are, quite potent as well. So I guess, honestly, I'd have to say that I use both, and it probably is pretty situational.
Yep. So just a question before my wrap up with you is, what other things do you place on your shortlist?
Yeah, that's a good question. Gosh. Well, on my short list are things, and of course this is hard to answer only because, am I talking about people in active treatment or people that have finished treatment and what kind of cancer? But we'll just go ahead and generalize.
Yeah.
And the things I find myself recommending the most often for my patients throughout all of that are melatonin. And I recommend high doses of melatonin, actually up to 20 milligrams, which I think is still an issue in Australia. But there's a lot of data on the benefits of melatonin throughout the continuum of cancer care. Medicinal mushrooms, for sure, are on my short list. And then 1 or 2 plant extracts that are high in flavonoids. So, in that would be things like turmeric, standardized to curcumin, green tea extract, quercetin, resveratrol. All of these are, beneficial in different situations. And then vitamin D is definitely on my short list. Great data coming out on vitamin D in all phases of treatment. And I guess I could go on, but then it wouldn't be a short list, so I'll stop there.
So, Lise, to my last question now. When you come out to Australia, what sort of things can the attendees expect to take away from the day? Because it's going to be a full day, 8 to 6.
Yeah, it's going to be a full day. So, first of all, I would say that my goal is that people will leave this workshop with tools that they can put into their practice the next day, that this will be very clinically relevant, and that the tools are going to be the tools of a greater understanding. We're going to do a deep dive into oncology, so they should feel really immersed in that world, and their clinical acumen should be sharpened as a result. They should also be able to leave this workshop with tools that they can put into place for people that come into their practice with the cancers that we're going to discuss, and that they'll be able to have some good therapies that they can recommend. They'll know why they're recommending them. They'll know how to recommend them. I think that the day is going to be fast-paced, so people who come certainly should not expect to take a snooze. It should be very engaging, and that's partly because there's going to be some Q&A time. There's going to be some case studies that we're going to go through. There's going to be some discussion and a panel discussion at the end, so we'll learn from each other. I think it's going to be a great day. I'm really hoping that people leave feeling very empowered, very excited to meet the needs of this population of people who we can so beautifully help. And they all that we need is to get them into our practices and provide them with our tools.
Lise, thank you so much for joining us today and sharing your clinical expertise, which is so important. It's such an interesting and important topic. So I thank you once again.
Well, thank you. I'm really looking forward to coming, and I'm looking forward to seeing you as well.
This is FX Radio, and I'm Andrew Whitfield Cook.